Starting things off with Section 1, Physiology and Functional Disorders. Let's establish the baseline for normal function.
Think of normal continence as a division of labor in the pelvic floor. It's actually pretty fascinating. Your internal sphincter, which is completely involuntary, provides 80% of your resting tone. On the flip side, the external sphincter is entirely responsible for your voluntary fine control, giving you 100% of your squeeze pressure. Oh, and your total rectal capacity? That sits between 650 and 1200 milliliters. Understanding this anatomical split is absolutely crucial when you're trying to figure out the root cause of fecal incontinence.
So what happens when a patient has severe incontinence but their sphincter complex is totally intact? Well, we look to sacral nerve stimulation. This is really a game changer and the most durable treatment option. But you don't just jump straight to surgery, it's a strict algorithm. First, a 2-week baseline bowel journal. Then a 2-week trial where temporary leads are placed in the S2 to S4 nerve roots. The magic number you're looking for here is 50. If you see greater than 50% improvement in incontinence episodes, that's your green light for permanent device implantation.
Now, applying this to structural functional disorders, your physical exam is going to make or break your diagnosis. Internal intussusception causes outlet obstruction and is usually managed conservatively with biofeedback first, with transabdominal rectopexy as a backup. But external rectal prolapse, that is a full-thickness protrusion. The absolute dead giveaway on your exam will be the presence of concentric mucosal rings. You have to distinguish those from the radial grooves you'd see in prolapsing internal hemorrhoids. Treatment for true external prolapse relies on surgical correction, like a rectopepsy or a perineal proctectomy.
Moving seamlessly right along to Section 2, Hemorrhoids and Anal Fissures. These are your highly tested bread-and-butter common pathologies.
The fundamental rule of hemorrhoids comes down to one single anatomical landmark, the dentate line. Internal hemorrhoids pop up above this line. Because they're covered with visceral mucosa, they don't have somatic pain fibers, so they present with painless bleeding and prolapse. External hemorrhoids, however, form below the dentate line. They're covered with anoderm, meaning they are very much somatically innervated. They don't typically bleed, but man, if they thrombose, they present with severe acute pain.
You definitely need to know the grading scale for internal hemorrhoids, because the management scales directly with it. It's like climbing a ladder. Grade 1 is purely medical, just up the dietary fiber and use stool softeners. By grades 2 and 3, where you see some prolapse, we introduce office procedures like elastic ligation. But pay close attention to grade 4. This is chronically prolapsed tissue that literally cannot be reduced manually. At that point, elastic ligation is off the table, and you have to escalate to surgical options like an excisional or stapled hemorrhoidectomy.
Now, if you do have to operate, you absolutely must know the complications. Urinary retention is far and away the most frequent complication of excisional hemorrhoidotomy, happening in up to 50% of patients. You can minimize it with careful perioperative fluid management. Oh, and another huge surgical trigger to keep in your back pocket? If a patient comes in with an acutely thrombosed external hemorrhoid, you excise it, but only if that thrombosis is less than 48 hours old. If it's been longer than 2 days, you just manage it expectantly.
Next up, anal fissures. Picture a literal split in the anoderm. The highest yield anatomical fact you can memorize here is the rule of 90s. 90% of these occur right in the posterior midline. Honestly, if you spot a lateral fissure, you need to immediately suspect an atypical cause, like Crohn's disease or TB. Patients will complain of severe tearing pain and spasms. But here's the good news. 90% of these heal just fine with medical management. Fiber, sitz baths, and a topical calcium channel blocker like 0.2% nifedipine. If all that fails, lateral internal sphincterotomy is your highly effective surgical backup, or you can try Botox for a temporary fix.
All right, on to Section 3, Anorectal Infections and Fistulas, where the spatial anatomy gets a bit more complex.
The most common anorectal infection you'll see is the cryptoglandular abscess. It starts in the anal glands right at the dentate line and spreads through the intersphincteric plane. The golden rule here? These demand immediate surgical drainage. But make sure to keep the incision close to the anal verge so you don't accidentally create a massive, long fistula tract. And listen to this. Doing a concurrent fistulotomy at this initial operation is strongly discouraged. Why? Because about 60% of the time, the abscess won't even recur, and doing a blind fistulotomy risks totally unnecessary and severe injury to the sphincter. Don't do it.
Now, if a chronic fistula does form, it's like a hidden tunnel system you have to map out. That's where the Goodsall rule comes in. It predicts the internal tract based on where the external opening is. Anterior openings tend to track straight in radially, while posterior openings curve around to the midline.
Alongside that, there are 4 strict anatomical classifications of fistulas you must recognize: intersphincteric, transsphincteric, suprasphincteric, and extrasphincteric. Your entire surgical approach relies on exactly which path the fistula takes.
So, how do we fix them? Well, treatment selection strictly depends on how much of that all-important sphincter muscle is involved. Fistulotomies are perfectly safe for low tracts where you're dividing minimal muscle. But if there's significant muscle involvement, you place a seton to manage the inflammation while preserving the sphincter. For sphincter-sparing techniques, the lift procedure is highly favored with a 60 to 75% success rate. And definitely note this specific scenario. For anterior fistulas in women, the endorectal advancement flap is the undisputed gold standard to preserve anterior continence.
Before we leave infections entirely, look at the stark contrast between these two presentations. Fournier gangrene is an absolute surgical emergency. It's a life-threatening necrotizing infection with a massive 50% mortality rate. It requires immediate, aggressive, wide surgical debridement and heavy IV antibiotics. On the complete opposite end of the spectrum is pilonidal disease. This is just an infection of a hair-containing sinus in the intergluteal fold. The key diagnostic feature: it distinctively lacks true anal pain. You just treat it locally with incision and drainage.
Finally, we wrap up with Section 4, anal neoplasms. We'll break this down by looking at tumors on the anal margin versus the anal canal. Let's start on the outside, at the anal margin. Atypical lesions here always get biopsied. Squamous and basal cell carcinomas are typically handled with local excision. Bowen's disease represents high-grade squamous lesions, and you'll often map those out using 9% acetic acid. But here is the most testable standout fact for the margin: Paget disease. If you diagnose this intraepithelial adenocarcinoma, it strictly mandates a full colonoscopy. Why? Because up to half the time, this signifies a coexisting signet ring cell carcinoma creeping down from the rectum. You cannot miss that. Moving inside to the anal canal, we encounter epidermoid carcinoma, and here is where the traditional surgical mindset gets totally flipped on its head. Upfront surgery is heavily deprioritized. Once you biopsy and stage it with CT and PET scans, your primary weapon is the NIGRA protocol. This is a very specific regimen of external beam radiation paired with chemotherapy, specifically mitomycin C and 5-fluorouracil. Radical surgery, like an APR, is held strictly in reserve, only to be used for persistent or recurrent disease.
Okay, let's do some active recall to lock in everything we just covered. Imagine this exact clinical scenario, pulled straight from the source text. A 54-year-old woman presents with pain and bleeding after defecation. You do an exam and find a 2 by 2 centimeter ulcer situated directly within the anal canal. The biopsy comes back as squamous cell carcinoma. Based on the algorithms we just went through, what is your immediate next step in treatment?
And the correct answer is primary chemoradiation therapy. Remember the NIGRO protocol. Upfront surgery is not the answer here. Mastering these precise clinical algorithms is the absolute key to conquering anorectal pathology on test day. We've laid out the clear baseline rules today, but what happens when a patient walks into the clinic with multiple overlapping pathologies at the exact same time? Keep these algorithms incredibly fresh in your mind, because the real-world clinical picture rarely stays this simple.